Hello. Thank you so much for coming tonight. Maybe a few more people will drift in. I'm Sue Ruff, President of the League of Women Voters of Broome and Tioga Counties. Welcome. Thank you very much for coming. This is a real important subject. Healthcare affects us all. As you're coming in, there's coffee, tea, and cookies in the back. Please help yourselves. There's a bathroom just down the hallway here if you need it. We have an annual meeting coming up here in Broome County, but people from Tioga County are also members and invited, and other counties very much welcome. Our annual meeting is May 19th. It'll be held at Southern Tier Independence Center, and there's information about it in the back. And our guest speaker that night is Blair Horner, who's very well known member now. He was executive director and then a member of the board of NYPIR, the New York Public Interest Group. And they're very involved in environmental issues. Blair, though, however, is also very well known in the Albany area because he knows what's going on, not only in front, but also behind the scenes. So you're very much welcome to come. There's information about that. I'm going to hand this microphone over to Susan Beckley to introduce our speakers tonight. Thank you very much for coming, and Susan, thank you.
Absolutely, glad to be here. Thank you everyone for coming out. We really appreciate you coming out on a Thursday night. I'm Susan Beckley. I'm a small business manager, and I will be doing the slide presentation a little bit later in the evening. But first, local practitioner, family practitioner, Dr. Keith Nichols will address the healthcare crisis as he sees it and through his experiences. And then Dr. Uphoff is a retired pediatrician who has been a pediatrician 45 years? 55 years. So she has seen a lot of the changes that have been taking place in healthcare and certainly in this area. So she will follow up about her experiences and what she's witnessing. Then I will continue with a slide presentation about the crisis as we see it in healthcare and a possible solution, New York Health Act, which is legislation that is in the health committees in Albany. So, Dr. Nichols.
Thank you, Susan. Okay. Thank you for that introduction. I'm Keith Nichols. I'm a family practitioner. I work in Owego, New York. I have always worked in Owego, New York since I came back home after the training period was over. I worked with my father and a lot of other doctors over the years, and I've been practicing about 47 years. So I don't have the experience in talking about healthcare financing and public declarations of my opinion of the healthcare crisis as the other speakers, but I do have experience providing healthcare, so I have a few words to say about it, and I'll keep it to a few words. Let me explain why I believe we are facing, or actually now in, a crisis in healthcare, not just around here, but the whole country. We're at a turning point, which I think is unstable. I think it's a critical time when our healthcare system really must significantly change or be brought down completely by accelerating dysfunction. The crisis in a pneumonia case, for example, is when the patient reaches a peak of fever and they either become septic or die, or they recover. Well, hopefully we're before the inevitable death of the healthcare system. I hope it's a transition rather than a complete falling apart, but I wouldn't be surprised if something has to fall apart pretty badly. Families' healthcare costs have increased by a factor of at least 3 times over the past 20 years, expressed as a percentage of our annual incomes. And we as a country spend more per person, more than twice as much per person, about $13,000 to $14,000 per person per year for healthcare, and that's compared to the next lowest country, which I think is Germany or Switzerland or one of those types of countries that is around $7,000. That's a remarkable cost. Yet, despite our relatively very high costs, we really perform quite poorly on the standard outcome parameters like infant mortality, maternal morbidity or mortality, even longevity or life expectancy, and our administrative efficiency, or the percentage of the healthcare dollar that has to go to administering the healthcare, is much higher here than it is in, I think, every country that has a single payer method of providing health care. Our medical costs are famously the leading cause of personal bankruptcy. 67% of personal bankruptcy in this country is medically based. That's 3 times the rate in Canada, which has national public health care. And our administrative cost is up around 20–25%. I could cite, just from my personal experiences, innumerable examples of the frustrations I've experienced providing family medicine over the years, and they've been generated by malfunctions in the system, a failing system, but we've been struggling along with it. I keep thinking something's going to change, but so far nothing's significantly changed. I've spent, and the staff, more the staff initially than me, but now it's me because I have no staff other than Jane, who runs everything, my wife Jane. But I've spent countless hours on hold trying to obtain prior approval for diagnostic procedures. And ironically, these diagnostic procedures are almost with 100% certainty going to be approved. They're always approved. I've never been, I can't think of one that I really wanted that they just said no. They always say yes, but yet it takes hours and hours to get them to say yes, and you have to talk to escalating level of technicians and so forth. It's a complete, utter waste of time. I think it must just make things cost more. It cannot result in savings, I don't think. The staff had to run the gauntlet on those all the time. And medications, like just this afternoon, I had to make like 4 or 5 different calls to get an elderly, agitated, and demented woman approval for a medicine, the only medicine that's been approved to treat agitated dementia. And it's very expensive medicine. That's a whole other issue, what our drugs cost, which is appalling. There's just an obstacle at every turn. I think I'll get her the medicine. I can't imagine that they won't approve it, but it shouldn't, it's just very inefficient. And this drives people to distraction, it frustrates them, and it makes them want to quit. So that's frustrating. According to Public Citizen, 29 hospitals outside of New York City and Long Island have a high to very high risk of closing or significantly reducing their medical services and of laying off workers due to budget cuts under the HR1. I refuse to call it the BBB. I'm not saying the words because I don't think it is the BBB bill. And I've seen just countless little kids with mouths full of decayed teeth, can't afford dental care, it's pathetic, and advanced cancers, unfortunately, that could have been diagnosed earlier. Sometimes it's denial that leads to the delay in diagnosis, but oftentimes it's fear of expense, no money, it'll go away, this kind of an attitude. People put off getting medical care, and things just get worse, and that's sad. Or if they don't have primary care physicians, which many people don't, they might go to an emergency room. an emergency room is inappropriate for a lot of diagnostic needs, or they might go to a walk-in, which almost inevitably doesn't help, because then they get referred to the emergency room if they have the slightest degree of complexity, which would easily be taken care of by any competent primary care provider. So that's bad. I worked up until recently at Lockheed, doing various things related to aviation and the helicopters. That's my main thing that I'm doing now since I retired, semi-retired. But I looked at the medical records of many of the young workers at Lockheed, and a really striking number of them have no primary care. They just don't have a primary care doctor. Where do you go? Oh, I go to a walk-in, whatever. And I mean, that's a choice, and I respect that that's the choice, but I don't think it's the optimal way to take care of people, and there are long waiting lists for primary care. Sometimes it's almost unobtainable. There's also the problem with the current system of what is being called moral injury in physicians and other providers, which is the psychological distress that results from being impeded by systemic constraints from providing optimal or even adequate care, which is different from burnout. Burnout is kind of like exhaustion or fatigue, boredom, or just tired of it, whereas moral injury is something different, and it's increasingly prevalent. It's significantly prevalent because people are being forced to work at rates much higher, seeing more patients per unit time than they feel is appropriate, bringing people back for repeat visits, like churning the visit and making more out of it rather than just dealing with things right at the moment in order to, this generates more patient visits. And there's all sorts of techniques for getting more money out of the insurer or the patient or something like that. That doesn't seem correct. The time is right, and it has been right, and now even more urgently is ripe for a dramatic change in our method of delivering what is arguably, after I've said all these negative things about it, the best, most technologically advanced and comprehensive medical system in the world. I mean, if you have something really seriously wrong with you, technically, that requires technical expertise, there's probably no reason to go anyplace other than the United States. You know, we just have superb medical care, but our primary care is crap, and the system is bad. And I think that the care should be delivered to everyone in a setting that's accessible, and where the system is sympathetic both to our individual differences and our universal humanity, not to be too highfalutin about it, and driven not by the profit motive, but by the acknowledgement that health is a fundamental right as I see it. And so if I seem too pessimistic or dark about this, I hope that I'm not. I still enjoy medicine. I never really felt burned out, but I do get super frustrated with the way it's set up, and I think that one of the particular reasons that the time is right is I think a lot of physicians and providers of every stripe, whatever PA, NP, the whole healthcare thing, I think that they're also feeling this, that it's just not tenable, it's not supportable, and there has to be something dramatic done to improve it. And I think that there will be a lot of support from the medical community, much more than in the past probably, for a big change, maybe to a single payer system. Okay, that's what I have to say. Doctor, yes.
Well, good evening. Thank you very much for coming and for listening. I'd like to thank Sarah Woken for inviting us, and I'd like to thank Dr. Nichols. I think I'm going to sound a bit like a broken record because I think we're on the same page exactly. We've had similar experiences in our respective communities. We've both practiced a long time. And one of the things I would say is that when I started practicing in 1971, we really worked hard to build up the kind of care that we could provide. And I saw so many improvements. And now I'm seeing it go down the other way. And I suspect Dr. Nichols would agree with that. That's happening, and it shouldn't happen. I came to Ithaca in 1970 after finishing my pediatric training at Upstate Medical Center in Syracuse. I took care of pediatric patients in Ithaca and the surrounding communities from 1971 until I retired in 2021 at the beginning of COVID. We have the best healthcare technology and the most skilled healthcare providers in the world. We can open coronary arteries within minutes for people who are having heart attacks. We can save very premature babies. When I started practicing, a 1,000-gram baby was one that, and I was at Stanford at the time. So we had high tech. We were just starting to put babies on respirators, but that was beyond what we could save. Now they're saving, and I personally have been involved in saving 550 and 600-gram babies that weigh 1.5 pounds at birth. But we have the technology. We have excellent, skilled practitioners, nurses, PAs, but they're hampered in what they can do because of the way the system is working. Our ability to treat cancer and prevent and treat deadly infectious diseases has improved. The seriously ill children that we took care of with meningitis, with epiglottitis, my younger colleagues don't even see anymore. They wouldn't recognize it. We need to take seriously how our healthcare system is working, and this isn't about immunizations, but I think of all the things I have seen that have been terrible outcomes for kids that now we don't have to put up with. And we have a generation of practitioners who don't even know what those things are, but they're going to come back if we don't keep up our good practices. When I started practice, Americans were leaders in healthcare. In 2026, Americans have poorer health outcomes and less comprehensive access to healthcare than do people living in all other wealthy countries. Babies born in the US are twice as likely to die before their first birthday than babies born in most European countries. Americans on average live 3 years fewer than most Europeans. And most alarmingly, as Keith said, the American's lifespan is getting shorter, not longer. America pays twice as much for health care that it does provide as do European countries, Canada, and Japan. We in America are getting much less value for the money that we spend on health care. And keep in mind that 27 million Americans do not presently have health insurance. Every other wealthy country in the world has health insurance for all of its citizens. And the question is, why don't we? Why can't we? And do people think about it? Our healthcare system is in crisis for a lot of reasons. One reason is because most people can't afford what it costs to get care. Many people can't afford the prevailing insurance rates, and even if they have insurance, they can't afford the co-pays, the deductibles, the out-of-network charges, the uncovered services. 1 million New Yorkers are without health insurance. 470,000 New Yorkers are about to lose their health insurance through the Essential Plan when the Big Beautiful Bill goes into effect in July of this year. Another 800,000 New Yorkers are projected to lose their health insurance starting in January of 2027, again as a result of HR 1. Our healthcare system is in crisis because people cannot easily get healthcare when they need it. We have a shortage of practitioners to serve our healthcare needs, especially primary care doctors, and especially in rural areas. Our healthcare system shows many signs of just not functioning well. It's been harder and harder for people to get to see a physician. Insurance networks limit the choice that people have of a physician. Healthcare reform should give more rather than less choice of physician. These days, few people have a relationship with a doctor whom they can call my doctor. For most people, when care is needed, they're sent to an urgent care clinic or to an emergency room, or they have to wait days or weeks for an appointment. Continuity of care, which has been a bedrock of good health care, has really been lost. Our healthcare system is in crisis because hospitals and clinics are financially unstable. 50% of hospital income comes from federal and state sources: Medicare, Medicaid, CHIP, and the Essential Plan, and some other sources. These sources, unfortunately, do not pay the hospital's full cost of care. Hospitals must, by law, continue to provide care without reimbursement for those patients who cannot pay. With cuts to government-funded insurance programs, many hospitals, and particularly in rural areas, are losing more money than they take in. Our healthcare system is in crisis because when hospitals and clinics lose money, they have to cut back on services, and at some point, they have to close. And that's been happening all over the country. And it's happening particularly in rural areas. It's happening particularly in upstate New York. Services that are needed in medical emergencies require highly skilled teams, like pediatric care, obstetric care, and interventional cardiac care. These services are expensive to maintain. In a rural setting, they are used less frequently than in a city. They do not generate enough income for rural hospitals to break even. But if you have a heart attack, if you live in Ithaca and it's 2 hours up to Strong, or it's an hour up to upstate, that may be a little too late for you. But we don't have as many heart attacks going on in our rural areas because our population is spread out. So that doesn't bring enough money into the hospital to pay for what it costs to keep a crackerjack team ready to go anytime it's needed. And that's something that can be solved, should be solved by state planning. But if it's handled by organizations that are in it just to make money, it's true that you can't provide high quality, skilled emergency services that take a lot of support if you're using them only part of the time. It just doesn't generate enough money. So we've got a problem that we've got to fix. And what's happening is when the hospitals have to close, or when they have to cut services, they cut the expensive services. A case in point is Cuba Medical Center cut its pediatric service 2 years ago. Now, if you have seriously ill children, they have to be transported from Ithaca to Syracuse or Rochester or Binghamton or wherever there happens to be a bed available. Doctors and nurses care about their patients. Doctors are leaving practice feeling burned out because supply cannot meet demand. Their time is taken filling out insurance company pre-authorization forms and fighting denials of care. Their professional judgment is challenged and thwarted by persons who are less qualified and specifically less invested in their patients' well-being. Doctors are thus unable to provide the standard of care that they aspire to. And That's the moral injury that Dr. Nichols alluded to. And as I talk to colleagues that I've worked with for years who are still in practice, I hear it more and more. They're frustrated because they don't have enough time with their patients. They're frustrated because the corporations that employ them are doing things that increase the cost of care, but are not providing care. Their judgment is second-guessed, and the rate of denial by the insurance companies is tremendously variable. But I just heard in Endicott that one of the denial rates was 70%. Doesn't mean that all of those tests requests are denied, but it's over and over and over again having to go through a system to get approval. And the end result of it is that it takes longer to get care, and if you're dealing with a population for which it's important, either they may just simply not last long enough to get the care, or they may decide that they're not going to get the care. So it's a way of not paying for care. At the same time, insurance companies are making record profits. About 1/3 of premium payments to insurance companies goes to administration and profit. United Healthcare, as an example, just had a record earnings quarter. A factor contributing to their record earnings was that they have cut insurance for some of their high cost, that is their sickest, Medicare Advantage and Managed Medicaid patients. Insurance pre-authorization and denials of care increase administrative costs for both practitioners and patients. It makes more administrative work for the insurance companies, but the delay in the denial of care increases the investor's return on their investment. This is a personal view, but it's based on more than 50 years of practice providing care for children in upstate New York. Healthcare should not be regarded as a commodity, like soybeans or petroleum, that investors should be earning a profit on. If the profits made by the insurance industry were redirected to caring for patients, our healthcare system could be robust and care could be provided for everyone who needs it. If we continue down the current path of bulking up administrative costs and taking profit out of the healthcare system, not investing in healthcare itself, we will be left with a broken healthcare system and a not very healthy, deprived population. It won't make any difference whether someone has a bronze or a platinum healthcare plan. If an intact and efficient healthcare system oriented to meeting people's needs is not in place, the care simply won't be there. Reforming the financing and organization of healthcare in the state and the country should be a highest priority for our community and for our government representatives. So thank you, and let me hand the mic to Susan Beckley, who will tell you about what so many people I've talked to don't know much about, and that's the New York Health Act.
Can I just have your attention for a second?
Sure.
If anybody's come in and they haven't signed in, we'd appreciate it if you signed in. We'll have the sign table, the table over there. You can sign in, because we would really appreciate knowing that you attended. That's all.
Thank you.
And thank you so far. It's been very good. I just want to say one other thing, too.
Sure.
This need here is tremendous. I worked for over 25 years for the New York State Commission for the Blind. And I had clients from ages 14 to over 100. And I saw the medical needs of these people firsthand. And it's been this way for many years, and it's time for it to stop.
Well, hopefully we can allay your concerns a bit.
May I also add, there's one statistic I'd like people to know.
Okay.
In Tioga County, on the 29 hospitals that are at high risk of closing in upstate New York, Tioga County has 8 of them.
I would like to have that list.
Yeah, it's out
For
there
sure.
for you.
Thank you. Yeah, I appreciate it. Because I have a list of hospitals that will be
I said
at risk of
Tioga, I
closing.
apologize, I meant Congressional District 23, so it's not just.
Okay,
Tioga County.
yeah.
Sorry, I appreciate it.
Okay, I think I have those.
Come on, Brian.
Oh, all right, so let's delve in a little bit further into what Dr. Nichols and Dr. Uphoff had to say in regards to the healthcare crisis as we see it. And then we'll take a look at the New York Health Act, which is legislation that is finished legislation that's in the health committees of in Albany and hopefully can address a good number of these concerns. So let's take a look at the healthcare crisis. What's wrong with our healthcare system as it is now? Well, as Dr. Nichols and Dr. Uphoff had to say, the United States is on average over twice as much as wealthier countries. And take a look at these countries, France, Canada, United Kingdom, Japan, Italy, and Korea. Keep those in mind a little bit as we go along. Those countries have universal health care and are on average paying less than half to cover persons for their health care needs. Life expectancy, as the good doctors had said, the USA is significantly lower than other Western countries. And here's our Japan and Italy and Netherlands, there's South Korea. So those ones are paying less than half of what we do. On average, they have increased life expectancies. In regards to this gap that is going on with life expectancy, in 1980, the difference between the lowest income group, lowest 25%, was only less than 4 years difference from the life expectancy of someone of the highest 25%. By 2010, so in 30 years, that gap has grown. And those people who are in the lowest 25% are 4 years less in life expectancy, while the 25% of highest income have gained almost 6 years of life expectancy. So something is not going properly with our healthcare system. Here we have the United States, worst life expectancy, infant mortality, as Dr. Uphoff was referring to, safety during childbirth. We're not doing well here. This is unmanaged asthma, unmanaged diabetes, very common, and heart attack mortality. So there's a lot of room for improvement. And that's without rationing. This is visits per person. So again, those countries we were talking about, UK, France, Japan, they have more physician visits per person than the US. Yes?
Are you saying that physicians go and visit people?
No. I'm just saying these are physician visits per person, that a person has 4 per year.
Okay.
Yeah. Okay, so what's creating all this, and how has it gotten so out of control? Well, we have the Affordable Care Act. It was reformed the prior system, but doesn't control costs. Costly, complex billing. It's non-universal, non-comprehensive, it's profit-driven, and rationed health care based on ability to pay. Also, this is the ACA. This is 11,000 pages of legislation for the ACA passage. This is equivalent to 44 inches of pages, 11,000 pages worth of regulations and legislation. So it is rather complex. As the good doctors were saying, increase of administrators. This lower portion that is in the light greenish color are the increase in physicians. Here's your administrators. So it does lead to additional costs. Well, yeah, this is managers, physicians. Duke Medical Center, North Carolina, 957 beds for their 3 hospitals, 1,600 billing clerks. Toronto University Health Network, 5 hospitals, over 1,200 beds, 7 billing clerks. They have one universal plan that reduces the need for all of those billing clerks. So something is amiss. And then, as we were talking about earlier, prescription drug costs. These are just becoming astronomical, just way out of line with what anyone can pay. And then we have these other little pieces. Health Now was sued in a whistleblower case for millions in overpayments. This is Buffalo's largest health plan is facing a federal whistleblower lawsuit overcharging school districts and state and government and federal governments by more than $85 million. So again, if you're going to have all this complexity, it's easier to overcharge. And then we have our health insurance CEOs. They're making $20 million, $50 million. These are annual salaries. So, and these are just the CEOs. So any of those other layers of management are making significant monies as well. They get stock options, they get bonuses, those sorts of things comprising their annual compensation. So what's the results of all of this taking place? Well, we have general inflation is 3%. This year, employer plans are having the highest increase in 15 years. The average 9%. I have one of my customers has an employee coverage plan that went up 15% since last year. So the portion that the employee is paying and the portion that the employer is paying will be increasing by 15%. Medicare Part B, highest increase in 4 years. Those premiums are up 10% this year. Marketplace, people who are individually going to the marketplace to get their coverage, 26% increase over last year in premiums. It's the highest increase in 8 years. But not only is that marketplace coverage for the plan increasing, but the out-of-pocket costs for those plans, which is your co-pays and deductibles. So not only are you paying more in premiums, you're also paying more out of pocket before the coverage kicks in. Let's take a look at Broome County. What's going on down here? These are the ACA marketplace premiums for 2026, giving you the Excelis plan. Lowest is the bronze, highest is the platinum. So for an individual, you'll be paying 12, and these are with the subsidies. So the federal government has put the subsidies against the premiums, and these would be the amounts, your income, how much of your salary would be going for these monthly premiums. The thing to pay attention to is the bronze plans have a $10,650 copay, which means you could be paying your premium, nothing is covered until your out-of-pocket deductible of over $10,000 in that year is paid. So, as we say, don't get sick in December, because in January, it starts all over again. And platinum plans, you can see how much and this is your gross salary. So this is out of your gross salary. You have to still pay your income taxes, your mortgage, your gas, your groceries, everything else out of your salary. And this is out of, that's here in Broome County. And also, there are no out-of-network coverage. So, if your physician decides that you need to see a specialist because of whatever unique situation you're in, and that physician is not in network, you're on the hook. Your insurance will not cover it. So that is limiting your choices. And it also constrains your physician as to where they can send you. If it's somebody out of a network and they know that they're out of network, can they find someone else who can treat that condition? So the out-of-network coverage is a very, very significant issue as well. And as was stated in regards to medical bankruptcy, these countries, our old friends from Britain and France and Germany and Japan, Canada, don't have people going in bankrupt due to medical debt. I don't know if the 700,000 is still that level. I wouldn't doubt it, but this was annually. 700,000 Americans were going bankrupt because of these medical costs. And the real sort of kicker with this is that they had insurance. They can't pay these deductibles. They can't pay these premiums. And if, like I said, if it is, you need out-of-state care, you need to go to the Mayo Clinic, the Cleveland Clinic, you need to go to Sloan Kettering, you need to have, or any of your family needs to have specialty care. If they're not in your network, you will need to pay out of pocket or go bankrupt. So here are some local health plan cuts in regards to what Dr. Uphoff was saying. The essential plan is like an adult medical plan through New York State. And with that, they determine those individuals who are eligible. And it has to do with income, so household of 1, 2, 3, 4, or 5. If you're below these figures, you will continue to be eligible for the essential plan, which is comprehensive, and it has dental and vision and hearing, as well as medical care. It was at this level before July 1st, when these cuts are supposed to go through. So these people who were earning this will be cut unless they're earning this. That's the 470,000 New York adults that are due to lose their health coverage by July 1st of this year. And Albany is scrambling, trying to figure out how they're going to cover all of these people, because it is due to a federal program. It's not due to New York State not providing that plan any longer. So, in regards to those facilities that are going at high risk, these are the ones in the nearby area. So, Guthrie at Cortland County, Delaware Valley in Walton, Krause Hospital in Syracuse, Arnott Ogden, Elmira, and Chenango Memorial in Norwich. So we say, oh, those are not in my county, so we're okay. Well, yes, but these guys close. Where are these patients going to go? They're going to come to your facilities and stress your facilities. And all of these employees are now unemployed. They will be looking for jobs, and they've lost their health care coverage. So it's important that we are aware that the risk is throughout the state and not just in these localized areas. Okay, so what are we to do? And how are we going to pay for it? Very importantly. So, as Winston Churchill said, you can always count on Americans to do the right thing after they've tried everything else. So let's see if we can try to do something else. And here's where we come to the New York Health Act. And how would you be affected by this if this legislation passed? So a little bit about the New York Health Act. It's a state bill, not federal. The bill numbers, S is for the Senate, A is for the Assembly. They have their own numbers, same identical bill. It would provide health care coverage to all New York State residents, regardless of age, ability to pay, or employment status. So if you get laid off, if your company moves out of the area, if you get sick, if you are changing jobs, or you want to start a new business, you're still covered. Your kids are covered. Your family's covered. Your brothers and sisters, everybody's covered. The person sitting next to you in the theater is covered. So it will create a single public trust fund where the money goes. That'll be through New York State, whereas Medicare is federal, that goes to Washington. It will pay for all covered health care costs. No copays, no deductibles. Okay, here we go. So this bill is finished legislation. It has passed the New York State Assembly 4 years in a row in the late teens. The bill is backed by a majority of New York State Senate and Assembly members. And patients choose their own providers and cannot be denied coverage. There is no in and out of network. So if your physician says that this is the person that you need to see for that surgery or your child's surgery or whatever, you don't have to worry about the cost. This is a huge relief to so many people and healthcare providers. All healthcare providers continue to be privately or publicly employed. This is not a government thing. They will be employed as they are now, including facilities and their employees. What's covered through this act is all medically necessary services and supplies, such as your primary care services, your preventative services, prescription drugs, the idea of not having to do co-pays and cut pills in half and skip dosages because you can't afford it. Those days would be gone. Specialists are covered, your hospitalizations would be covered. Medically necessary services and include mental health services, including rehab, dental, vision, and hearing. So those kids with bad teeth and all will be seen. Long-term and home care and skilled nursing care will be covered. Medically necessary supply costs, which are, for example, the walkers, prescription glasses, dentures, hearing aids, wheelchairs, are medically necessary, they would be covered. New York Health Act is affordable, simple billing, universal, covers everyone, comprehensive, which means that it includes everything that's medically necessary. It's accountable to a public board, not to CEOs and private people that you don't know who they are and where they are. And there's no rationing of care based on the ability to pay. And as an example, with our ACA over here, here's the New York Health Act. Now, this is the goals. This is what is laid out here, and certainly there's going to need to be lots of fleshing that out. But this is covering 50 states. This is for New York State. And it has been worked on for 30 years, so it is pretty solid and has been able to pass in the Assembly. So, what savings can we realize if the New York Health Act passes? So this is what we're looking forward to happening. First of all, you have no agents and brokers fees. You don't have these high administrative costs, up to 30% for private insurance. You don't have the prior approval of healthcare. You don't have the out-of-network costs. All of that is covered by the New York Health Act. You don't have those dividend payouts to shareholders and the shareholders requesting better profits and bigger bottom lines. You don't have drug costs that are not negotiated. All of those drug costs that are skyrocketing will be negotiated now by the state. And so the state now has 20 million people that it can negotiate for. Our population is greater than any individual Scandinavian country. If they can do it, we have 20 million people, we should be able to do it. We don't have any enormous CEO and upper management salaries, stock options, bonuses, all this business. And then we don't have the large premium increases, which currently double every 8 years. You don't have any yearly health insurance plan negotiations. No searching and comparing plans every year. Right now, the Medicare recipients, as well as employers and people in the marketplace and employees, are renewing and changing plans on an annual basis. So if you have an employer and you like their plan, if they decide to change that plan for the next year, you don't have a choice. That is your plan for the next year. Unless you want to go off by yourself and not take the employer plan and pay for something else entirely on your own. It eliminates that endless paperwork. All of those billing clerks for recipients, businesses and providers. I mean, the reason that Toronto has so few billing clerks is because they don't have all of this complexity to deal with. And now you can budget your health insurance costs. You know what it's going to cost and how much you can plan. All those school districts have no idea what the plan is going to cost the following year, and their budgets are impacted severely, and we'll see that, by not knowing what the increases are going to be the following year. And this eliminates the fear of bankruptcy and medical debt, which certainly is a huge factor for many, many people. And public programs can control costs far better than private. Here are your private insurers, and Medicare and Medicaid is way lower. And even when you look at the modest increase with Medicare and Medicaid, the health insurance industry is getting into Medicare and Medicaid because they can see that there's lots of money to be made with that. So that's your Medicare Advantage plans and the Medicaid plans. So it's creeping up a bit. Here, lower drug prices through greater bargaining. We're paying 3 times as much as all other countries. Just bottom line, for brand name drugs, the United States on average is paying 3 times as much as wealthier countries. Just for drugs. So, this all sounds nice. How are we going to pay for it? And who's running the show? What's behind all of this? So here is the revenue. 100% is about $335 billion a year. Well, currently, federal funds, those Medicare, Medicaid, CHIP, ACA subsidies and all, are comprising almost half of that budget as it stands now. The New York Health Act provides for non-payroll taxes and payroll taxes. The balance, about a third of it would be from payroll taxes, and non-payroll taxes would do the other 2/3 of that balance. So federal funding that New York has already received will be contributed to the trust fund. So that's Medicare, Medicaid, CHIPS, ACA subsidies, and any other federal programs that miscellaneous coverage of healthcare costs. Non-payroll income is, now this is on taxable income. So non-payroll income is the gains that people make on capital gains, interest, and dividends. So that will be contributing to the trust fund as well. The payroll estimated taxable income again, but the first $25,000 of the taxable income is not taxed. So there's no tax for the New York Health Act on that first $25,000. If you're a Medicare recipient, the first $50,000 doesn't require a contribution to the New York health tax. 80% of the tax paid by the employer and 20% by the employee of the payroll estimated tax. These are all part of the proposed legislation, so it is in the bill. Give you an idea, this is what is in your handouts as well, to give you an idea of roughly the cost. If this would be if it was an hourly wage, this would be if it was a salary. And this would be 100% of the monthly cost, but if you were employed and had an employer, that would be the employee's cost, and that would be the employer's cost. Now, this is not in the bill. This is from an economic analysis done by Leonard Rodberg. This is from 2024. There are continuing studies being done on this to get an idea of how much would be withheld from people's wages. So, and it would be withheld from individuals' wages along the lines of how Medicare and Social Security is withheld from your paychecks now. If you were self-employed, it would be, after you file your taxes or whatever that you would owe on the New York Health tax. Okay, so who's in charge of this bill? It's a 45-member board of trustees. They are state officials appointed by the governor and legislative leaders. Now, to me, the beauty of this bill is that it states within the bill itself that 31 members must include representatives from these organizations, types of organizations. So you have doctors' organizations, community health workers, non-physician health workers such as nurses, hospital representatives, a public hospital representative, representatives organized labor such as teachers, healthcare consumer advocacy organizations. So this, to me, looks like a much fairer representation of how to provide health care to our residents rather than corporate individuals who are not having medical backgrounds or associations in the medical field. The other piece of this legislation, which is really quite nice, is that this board is advised by 6 regional councils. So there's the New York City one, the Long Island one, Northern New York, Hudson Valley, Central New York, which is us, and then Western New York. They have a minimum of 27 members, again, from these types of organizations. And they are to advise the board as to what's going on in your part of the state. Okay, so finally, how will your local and property and school taxes be impacted by this, by the adoption of the New York Health Act? So your property taxes are not only paying into the budget for the services, but your property taxes are also paying for the medical insurance of all of these employees. So with that, your budgets for your school budgets, your county and city budgets are a lot greater because of paying for health coverage for these employees. And the other piece is the Medicaid mandate, which 25% of your county's Medicaid expenses are paid from your county. And so this mandate is county by county, and your county, part of your budget, has to send that money to Albany to pay 25% of the Medicaid expenses for your county. Let's take a look at Broome County. Local savings realized, again, this is with those figures that Len Rodberg came up with as an economic analysis. First of all, the Broome County mandate for Medicaid goes away. It goes back to Albany. That is equivalent to 36.6% of your entire property tax budget. So right now, you would have, right off the bat, 20 million, don't have to pay on an annual basis. Broome County employees, if you take a look at the county budget, you would save over $10 million just on the health insurance costs for these employees. And these employees, they continue to be covered by the New York Health Act. This is the difference of what's being paid now for their health care coverage with their co-pays and deductibles and out-of-network charges. You would save over $10 million on Broome County employees. Union Endicott School District, your school district taxes are paid based on property taxes. You would save almost 15% of your school budget for Union Endicott this year, over $17 million. The school district can probably use that for a lot of things. And Binghamton School District will save over 13% and over $20 million in the city budget. Again, all of these people would be covered, but you will have local savings. So if you want to talk to your school board people or your county representatives or whatever as what to do with that money, how much of it's given back, how much is used for other things in the district, you have more of a local say because this is in the county. You can show up at the meetings. It's not like you have to go to Albany yet or to Washington. You have much more control over this because it is local and it's your property taxes. So, is the New York Health Act the answer? It's up to you to decide, and it's your choice. So, for any more information, there's a campaign for New York Health, nyhcampaign.org. And if you have any requests for slide presentation for groups, you can contact me at my email, and I will respond in regards to making any presentations throughout the area. Thank you. So we have with us Richard Gottfried. He's the retired assemblyman who authored this bill and has been its greatest advocate. And he is with us via Zoom in order to answer any of your questions. If you have questions about the slides, please direct them to me. This is not his presentation, and he can't see what was just said. So, there we go. Oh, there's Dick Gottfried. Hello, Dick. Can you hear us?
Hello.
Okay.
Yes?
Okay, good. So are there any questions? The fellow behind you.
I vote yes. The question I have is, I was very impressed by the two doctors we just heard. Are their salaries going to be properly compensated, or are they all going to move someplace else where they get paid better?
I believe they're retired or semi-retired.
In general.
In
In
general.
general, doctor salaries. he's
I'm sorry?
Doctor salaries
Doctor
in general.
salaries.
Oh,
Yeah.
oh, I see how well they be
Right.
compensated for. So Dick, about compensation for physicians in the event that the New York Health Act is passed.
Yeah, well, first of all, just one note. So we've heard tonight from a pediatrician, and the New York State chapter of the American Academy of Pediatrics endorses the bill. We heard from a family physician, and the New York Academy of Family Physicians endorses the bill. And, the bill declares that Medicare and Medicaid, their rates of payment, which everyone knows do not really cover the real cost of care, do not meet the standards of the New York Health Act. The bill has language in it describing how physician and other healthcare provider compensation will be set. And interestingly, that language in the bill, we had a meeting a few years ago with the Manhattan chapter of the State Medical Society, and they gave me some thoughts about how they thought doctors ought to be paid. And I took careful notes and wrote it up, and I sent it back to them, and I said, is this what you want in the bill about how doctors and other providers will get paid? And they said, exactly. Now, the medical society is pretty focused on making sure that its members get adequately paid, and they helped write the language in the bill that talks about how reimbursement rates for doctors will be set. And doctors will spend a whole lot more time taking care of patients, i.e. doing what they went to medical school to do and getting paid for it. rather than all the time they now spend every week fighting with insurance companies. Unpaid medical bills will be a thing of the past. Doctors and hospitals and others will actually be very well taken care of under the New York Health Act. And that's because our dollars are going to be spent not on insurance company bureaucracy and executive salaries and profit and the like, but rather spent on providing health care for real people.
I understand that this bill has passed the Assembly several times. What's holding it up? Why hasn't it been passed and in law now?
Well, when we had a Republican majority in the state Senate, what was stopping it at that point was the Republican majority basically taking orders from the insurance industry, which of course does not like the bill because they'll have to concentrate on, selling car insurance if the New York Health Act passes. Now that we have a Democratic majority in both houses, a lot of the labor movement supports the bill, but some segments of the labor movement, particularly the state and local public employee unions, by and large oppose the bill. And I think that's because their leaders like running for re-election on the platform of vote for me, I got you good health coverage, even though the New York Health Act would give their members much better coverage at a lower price, but they don't talk about that. With that opposition, it's very difficult now to get a bill passed in a legislative body with a strong Democratic majority, because the public employee unions are a major part of the political constituency of the majority in the Assembly and Senate. So what it's going to take is either the rank and file in those unions getting together and getting their leadership to change their position, and some of that activity is beginning to happen, or other organizations around the state, whether it's the League of Women Voters, which supports the bill, or others, getting a lot more vocal in support of the bill, so the legislature understands that they better get this done. I mean, because as of now, the majority of the members in both houses are co-sponsors of the bill. But the leadership is politically, at this point, unwilling to move it.
I know in other states, and I have a relative in Idaho, lives in a fairly large village, and the closest hospital is 90 miles away. So my point is this: I've seen 2 lists in the last week of possible hospital closures. One of them is one of the UHS facilities in Binghamton, New York, and then the other one this evening was the Guthrie unit at Cortland, New York. So one is, is that short term? Is it long term? Is it those hospitals specifically, or how is that information available, and can it be substantiated that it's those units?
Well, hospital closures have been an issue in New York State for a long time. And, some of that is because, not too long ago, if you went into the hospital, you might stay a week and you fill up a bed for a week. Now you're probably coming out in a day or so. So you're only filling up that bed for a day or so. And so we need fewer hospital beds than we used to, and that's a good thing. But what's happening now is I had hospitals in my district. My district in Manhattan that I used to represent is one of the wealthiest legislative districts in America. It's very much not a poor rural area. And that area had 2 or 3 hospitals closing because insurance companies didn't see the need to pay them a lot of money. And so they folded. And around the state, hospitals are closing because insurance companies don't want to pay them, or they're losing money from cuts in Medicare and Medicaid and other things. I always say, there are no Medicaid nurses in a hospital. If Medicaid gets cut, the hospital has no choice but to cut back on personnel. And that means even the wealthiest patient arriving with a heart attack is going to get care that is stretched thinner and be more likely to die. And with insurance companies consolidating and getting more economic power that is unaccountable, hospitals are consolidating and shutting down their weaker elements and moving the beds, into the main branch of a hospital network. And so communities are losing their hospitals. And that's going to continue to happen as long as we've got profit-making insurance companies controlling our healthcare system. Because they don't care whether your hospital is open or not. They just care about making money. Under the New York Health Act, hospitals will be more fairly paid, and hospitals will not have to deal with some mega corporation that's not accountable to the public.
Thank you. So just 2 follow-ups to that. So then it might be a little like hotels then, where you need a occupation rate. In other words, if not all the beds are being utilized, then that might be a strictly financial situation based upon the conglomerate that owns the hospital, maybe. And so what I'm saying is that a fair statement? I'm trying to hone in on why the hospitals are closing. Maybe it's a P&L situation or whatever, or maybe it's based upon occupancy of beds. I mean, if it says that 2 hospitals are closing, then, or maybe closing, then there has to be some rationale to back that up.
Well, it's a combination of things. It's hospitals not being paid fairly by Medicare and Medicaid, and the New York Health Act will fill those gaps. Some of it is a decline in the number of beds that we need. Some of it is hospitals forming mergers and moving beds from small hospitals into, the mothership in order to compete more strongly with consolidation on the insurance side. So it's the insurance monopolies that are hurting a lot of our local hospitals. And again, an awful lot of those factors go away if we have universal, publicly accountable health coverage under the New York Health Act.
Thank you.
If you get angry at, United Healthcare, does anybody have any idea who's on the board of directors of United Healthcare or where they meet? No. You and I have no idea. The head of your local hospital has no idea. But we all know who our legislators are. And by the way, under the New York Health Act, our governor and our legislators and all their staffs and all their friends and their family members and their campaign contributors will be covered by the New York Health Act. They will have a vital personal interest in making sure that the New York Health Act treats them and their doctor and their hospital as well as can be, and 20 million of the rest of us get to ride on that same boat.
Thank you very much. I would just say as a
Yeah.
closing remark, though, that I think that, not being on it, but I think the ACA has been one of the best things that has happened in this country for a lot of years for healthcare. Now, with that being said, it is 11,000 pages or whatever it is, but that's the only thing they could get through Congress, though. That was a tough battle. It was succeeded, being ripped apart now by legislation, but so I'm hopefully that none of us knock the ACA just for the sake that it helped so many people at the time and still does. But thank you for your remarks.
You know, the ACA was and for now still is very important legislation and has helped a whole lot of people. And our president is doing his best to trash it. But, you know, even with the ACA, you've still got, you know, restricted provider networks and deductibles and all of that. You know, it's like if you're crossing the ocean on an ocean liner and it hits an iceberg and sinks. Having a lifeboat or floating wreckage to cling to is better than drowning, but not having your ship sink is even better. And the New York Health Act is even better than having a lifeboat.
Hello, sir. I'm Marita Florini. I've been following your career for years, and thank you for everything you've done in the Assembly. I appreciate you. I just had sent you.
Thank you.
I had sent you questions which you kindly answered to me. I'm just going to pick out a couple of them for you to go over with the audience tonight. Just some technical questions like, what about the snowbirds who leave New York State for the winter? And what about travelers to our area or people who maybe live in Pennsylvania but work in New York? How will those things happen?
Okay, well, those are two sets of different questions. A New York resident who is temporarily out of state, you know, whether, and I think of several examples of that, somebody who spends, you know, the winter in Florida and needs to go to the doctor, somebody who's hiking in the Grand Canyon and breaks their ankle and needs to go to the emergency room, somebody who lives close to in a town close to the Pennsylvania border and their family doctor is down the road on the Pennsylvania side of the border, or the local hospital is on the Pennsylvania side of the border. In all of those cases, the New York Health Act has language to say that if you're going to an out-of-state provider for reasons like that, the New York Health Act will cover the bill, as it should. Now, if you live in, let's say, Pennsylvania and you work full-time in New York, the bill also says you will be covered by the New York Health Act. And, you know, that's partly because if you're, you know, in an office and you're at one desk and a couple of feet away is somebody at another desk, you both ought to have the same health coverage. So the New York Health Act would cover you if you work full-time in New York but live in Pennsylvania, Connecticut, what have you.
Thank you.
Yeah.
This question came up because of my experiences in the past with thinking about single payer and universal health care. There was some concern in the past that, you know, initially we'd see all this savings, but what would happen 10 and 20 years down the line? Will we still control the costs down the line?
Well, absolutely. First of all, in the future, with our current system, everyone knows the cost of an appendectomy is going to go up. The cost of health coverage to cover that appendectomy is gonna go up. It's gonna go up faster than inflation. How do we know that? Because that's what has been happening for years and years in this country, and it's gonna continue to happen. Now, under the New York Health Act, you know, the cost of bandages or anesthesia or whatever else health coverage pays for, yeah, that's gonna go up. That's, you know, there is inflation in the cost of a healthcare service itself. We won't have to worry about paying insurance company executives more. And while the cost of an appendectomy will go up, the incomes that support the New York Health Act taxes are going to be going up. And so it balances out. So the savings that the New York Health Act depends on are permanent. We're not just going to save $60 billion, which is the figure, in the first year. Those savings are permanent. And what we would have spent 10 years from now on insurance company salaries and all the rest, it's going to be a whole lot more than 60 billion if we don't do something about it. So the notion that somehow the savings under the New York Health Act will disappear in the future or be reduced in the future, there's no basis for thinking that.
Okay, thank you. My last question, I had asked about market or stakeholder fluctuations. By that I mean, okay, let's say for whatever reason we're, thank God, able to get this through this year. There'll be a transition period. There may be other legislation that has to happen to get the rest of state laws in line. But now let's say we flip everything over. I mean, we have a Democratic governor and legislature now. Let's say it flips to Republican or even independent. What's to prevent the cancellation of all of this in the future?
Well, obviously, you know, we can't control what future governors and legislators will do, but we can look at history in this country. And when a major program that benefits a huge chunk of the population becomes law, you rarely, if ever, see it rolled back. And for example, Medicare, Medicaid, public education, these are things that are enormously popular. And, you know, regardless of who gets elected, it's really hard in this country to roll back a program that really works and is widely popular. And the New York Health Act is going to make an enormous difference in the lives of all 20 million of us. It's hard to think of any piece of legislation in the history of New York State that will make as big a difference benefiting as many New Yorkers as the New York Health Act. The likelihood that the legislature in the future is going to be inclined or able to roll it back is pretty slim.
Thank you.
Thank you. Another question?
So I want to pick up on a couple things, piggybacking off of what you just said, and something that you said earlier about why this has not come to be. And you said the public employees are not backing it. And I'm hearing unions. I don't know if that's what you meant or not, but the rates that teachers pay for health care is negotiated. It has been negotiated over decades. And we've given up a lot to keep our health care costs down. So if next year we have all these Republicans in office and they decide to get rid of this program, and we've lost what we fought for decades, that's going to be a really hard pill to swallow. So I think look at unions a little bit differently. they all have to agree to any contract that is, negotiated by their leadership. And so the rank and file are already there with their leaders. We don't want to lose what we have fought so hard for. So if you can find a back door, like, okay, if the Republicans come into power, they get their contracts back, or something like that, it might be an easier sell for that group of people.
Well, public employees, like 20 million other New Yorkers, are not going to lose anything by enacting the New York Health Act. In fact, they're going to benefit enormously. Either they or the school district that calculates what to pay them every year is going to spend a lot less on health coverage because what they spend will be going for health care, not insurance company profit, and it will cover long-term care, which half of us are going to need at some point before we die. There will be no more deductibles or co-pays, et cetera, et cetera. You know, I've talked about this issue with a lot of labor leaders. Every one of them tells me every time they're at the bargaining table, they are under pressure to either cut the health plan in order to protect wages or cut wages in order to protect the health plan. Under the New York Health Act, they won't have to do that anymore. And so public employees are not going to lose what they have. The only thing they're going to lose is a whole lot more money being taken out of their paychecks. A lot less money is going to be taken out of their paychecks, and they're going to get a lot better coverage. That's not losing something, that's gaining a whole lot. And you know, my entire career was spent as a public employee, as a member of the legislature. I know what the health benefits are, and as a retiree, I know what the retiree health benefits are, and I know that under the New York Health Act, the benefits will be a whole lot better, and the cost will be a whole lot less.
Thank you. I just wanted to make a point in favor of the public employees. I was president of my retirees union for over 10 years, and we were lobbying for universal health care. I remember making several presentations myself on promoting universal health care, and the AFL-CIO has also been in favor of universal health care. So while there are some that are not because they like to have the benefit of having it there when they negotiate because it makes them look like big shots, but there are a lot of public employees that are much more in favor of, you know, a single-payer health plan because it saves us a lot of money and it gives us decent insurance. And that's what we all want. And that's what we all need to have. And then there's the security part of it. You know, when you have good health care. And as part of being a public employee like you were, I've been fortunate to have decent health care, you know, most of my adult life. So I appreciate that. But it hasn't been perfect. So, and not that there is anything that would be perfect, but I hope somehow we can get this, because I've been advocating this for, you know, I don't know, 20 years. And I just hope that, like you, I hope we can somehow get it through because there's just such a benefit for a single payer. So, thank you.
Well, thank you, and you are 100% correct. And by the way, not only did I spend my entire working life as a New York State employee, but my mother was a New York City high school teacher her entire, well, not her entire working life, almost her entire working life. and was a member of the United Federation of Teachers pretty much from the day it was organized, and was a member of something called the Teachers Guild before the UFT was organized. And in her last years, she needed round-the-clock home care, and the cost of it pretty much, well, wiped out almost all of a lifetime of savings that she and my father had put away. And with the New York Health Act, that would not have happened. So you're absolutely right. And there is a growing movement among public employee retirees and active employees among the rank and file trying to get their leadership to see the light.
Richard, good evening. First of all, thank you so much for being here tonight. Thank you, Susan. Thank you to everyone who spoke tonight. This has been really informative. This has been a really great presentation tonight. My question relates to emergency medical services. I know that rural ambulances are really in crisis right now due to the fact that they're not getting adequate funding. And I'm wondering if the New York Health Act is going to do anything either by virtue of direct payments to ambulance companies for care services provided, or if that's something that's going to have to be addressed by separate legislation.
No, emergency care, ambulances, EMTs, etc., will all be fully covered, and that's guaranteed in the bill. And they will be fully and fairly paid, like other healthcare providers. You know, what happens today often is, you know, the ambulance rushes to the scene, picks you up, takes you to the hospital, and then you as the patient are told by your insurance company, sorry, the ambulance was not in our network, and so we're not going to pay them. And maybe you can come up with a couple of $1,000s to pay them out of pocket. Maybe you can't. And if you can't, then the ambulance company is out a couple of $1,000s. And it's hard for an operation like an ambulance corps, whether it's a company or a volunteer service, to keep its head above water. If they're always fighting with insurance companies or not getting paid at all because the person they pick up can't afford an out-of-network payment to them. So ambulance services and EMTs will be much better off financially under the New York Health Act. And you know, as someone who has occasionally taken a ride in an ambulance, not by choice, as a lot of us have, I cherish that service, and I want to make sure it's there next time I need them.
Richard, one more question for you. It kind of tails on to this. I know that if you show up at the emergency room needing medical treatment, if you don't have the ability to pay, the hospital is obligated to treat you, and then that cost is typically passed on to other individuals who are using healthcare services, or even sometimes to taxpayers. Can you speak to how the New York Health Act will help kind of reduce the cost to folks who are already paying this expense?
Well, sure, because hospitals that have the economic power to do so will charge their private insurance patients a lot more than Medicare and Medicaid pay, because the term in the industry is they are cross-subsidizing Medicare and Medicaid and uninsured patients by charging people with commercial health coverage a lot more if they can squeeze it out of the insurance company. Under the New York Health Act, they won't have to do that anymore, because New York Health will fill the gaps where Medicare and Medicaid and today uninsured people don't pay their way. The New York Health Act will make sure that hospitals no longer have to, cross-subsidize from Medicare and Medicaid paying inadequately, because New York Health will fill the gap. They will no longer have unpaid medical bills, because the New York Health Act will cover every New Yorker. In the last several years, the legislature has made it almost impossible for a hospital to collect an unpaid medical bill from somebody who doesn't want to pay it. Now, am I glad that we're protecting people from being sued by their hospital if they can't afford to pay? Yeah, I'm glad, and I helped write some of that legislation when I was in the Assembly, but I'm glad I'm not a hospital executive trying to survive in a world where if somebody doesn't pay their bill, there's really not much I can do about it. But under the New York Health Act, in New York, there will be no such thing as an unpaid hospital bill. And we will all benefit from the fact that our hospitals and our doctors and our physical therapists and everybody else will be fully and fairly paid.
And Dick, just to elaborate a little bit on that, no, there will be no balance billing with this, so no one's going to receive a medical bill in the mail. It will all be covered by the New York Health Act, is that correct?
That is correct. The bill very explicitly prohibits what in the business is called balance billing, where the health plan will pay $500 and the doctor says, well, I want you to pay me an extra $300. That will not be allowed under the New York Health Act.
Thank you for your time. There sits in Assembly and in New York State Senate a bill, and they're still looking for communication with one another, but it has to do with making ambulance services essential governance, much like fire districts are now. Because of all the ballooning costs of the fire districts, both the Republican and the Democratic Party don't have a lot of love for this. Obviously, it would correct the rural ambulance services where they're driving 40, 50 miles to a hospital on every run instead of going 6 miles for a city operation. And that's where the cost is. It's primarily in the travel cost of the rural ambulance services. Now, so based upon the sitting Senate bill and the sitting Assembly bill, both Senator O'Mara, State Senator O'Mara, is telling us there's no traction in the Republican portion of it, and NYCOM, New York State Council of Mayors, just told me as recently as last year that there really is no traction on their part either. They back it, but they don't see a lot of it happening. It's sitting there, and then obviously then it would be, if it were to happen, it would be turned over to the county's responsibility, each one of the New York counties, and in fact they would apportion the districts, and then it would come up for vote, much like fire districts do now. But until there's a change, that's not going to happen, and that itself is sad. What you are talking about tonight is fantastic, but that's a fix also. Thank you.
Yeah, I'm not familiar with that bill, but if Gustavo Rivera is sponsoring it, he's a good friend of mine, and if he's sponsoring the bill, it probably is a good idea. But an even better idea is that the ambulance service not be paid by city and state property taxes, but be fully paid by the New York health system, which is will be based on progressively graduated taxes based on ability to pay.
I have a question. If you are admitted to a nursing home today and you are Medicaid, you don't get a proper reimbursement, as you know, and yet it's an all-inclusive rate. If I go as a private pay, I pay for every single thing separately. You know, I pay for PT, I pay for drugs, I pay for everything. So I guess my question is, and of course, the nursing homes are trying to make up money lost by Medicaid with private pay. So it's limited and difficult to get into a nursing home if you're Medicaid compared to if you're private pay, and I'm sure you know that. So I guess what I'm saying or asking, am I right in assuming that if you're in there under the New York Health Act, everything will be paid just like it would be if you were Medicaid? Do you know what I'm saying? That it's an all-inclusive rate kind of thing, so that when you're in, the advantage is that the disadvantage of being Medicaid versus private pay could sort of go away because your coverage would be complete, all-inclusive.
Yeah, and under the New York Health Act, you will not have to, as they call it, spend down to poverty in order to be covered by Medicaid. And the services that you were talking about, physical therapy, etc., will all be covered by the New York Health Act. And the nursing home will be paid better than than Medicaid now pays them, thanks to the language in the bill.
I have another question too, which is sort of a throwback to one you were answering earlier, and that is, if I live in New York State and I work in Connecticut or some other state, am I paying my 20% for the bill for my health insurance, and do you not get the other 80% from the employer? How do you get that?
Well,
how do you get their share?
Yeah, there are, I guess, basically three possibilities if you are a New York resident and you're working in, let's say, Connecticut or Pennsylvania. One is that your employer is currently paying for health coverage for their workers, including you, and under the New York Health Act, they will, if they pay your New York Health Act tax, payroll tax, it will be a lot less of a hit on them than what they're now spending on your health coverage, because the New York Health Act taxes are going to be, in almost every case, less than the cost of private health coverage. So your employer, who is today willing to spend a lot more money on health coverage for you, will be happy to pay their share of the New York Health Act tax for you. Another possibility is that your employer will have what is legally called enough contacts with New York State to be subject to New York State law, in which case they will be required by the New York Health Act to pay at least 80% of the payroll tax on your income. The worst case scenario is that your employer, who is today probably not chipping in a nickel for your health coverage, won't chip in for your New York Health Act taxes, and instead of you paying 100% of your health insurance premium, you will pay 100% of your New York Health Act payroll tax, but it'll be a smaller amount unless you are an extremely high salaried worker. So in almost every case, as a New York resident working out of state, you will be financially better off under the New York Health Act.
Last question.
Thank you so much, Assembly Member, for coming tonight. Many of us have followed your career and your efforts all these many years, so thank you. Have hospital executives around the state supported the bill or just stood on the sidelines?
The Hospital Trade Association, I mean, there are some hospital executives who support the bill. A fellow who just retired as head of Lifedale Children's Hospital in Westchester strongly supports the bill. Mitchell Katz, who is head of the New York City Public Hospitals, has strongly supported the bill through several different mayors and continues to. But the hospital trade associations do not support the bill. I think, like a lot of business people, when they hear government program, they think, oh, it's probably going to screw me. But I think it's pretty clear they're going to be a lot better off under the New York Health Act. One thing I try to remind them is that, until 30 years ago, most people don't know this, New York State for many years regulated what insurance companies pay to hospitals. And the hospitals did very well under that legislation because legislators, when choosing between benefiting the insurance industry or benefiting their local hospital, darn it, they wanted to make sure their local hospital was well taken care of. And what finally killed that program in 1996 was when Governor Pataki, Republican, said on behalf of the insurance industry, which hated that system because we made them pay, Pataki said, don't bother negotiating a renewal of that system this year because whatever you negotiate, I'm going to veto it. And that was the end of that. But I keep reminding the hospital executives, the legislature treated you pretty well because legislators like to make sure that the hospital that they and their constituents depend on will be as well treated as possible. And that means the New York Health Act. But yeah, so far they're nervous about it because, they hear government and they get antsy.
Yeah, they do. Is there pushback or intransigence, basically just not moving, from the head of the Assembly, Speaker Heastie, and the Senate leader, Stuart Cousins? They have so much power about which bills get to move. When you look at these bills and you see all the co-sponsors, and yet they still sit in committee, that really bothers me, because we have a system and bills should have an opportunity to go forward and to stand for vote. So any advice you might have in terms of advocacy that we can do with those individuals or with whomever seems to be putting the brakes on. Because I think overall people don't want to go bankrupt. People want to be able to take their kids to the doctor and also see to it that their parents have care as their parents are aging. So something that makes so much sense that doesn't move, it bothers me that people who are in power have the ability to move it, but they haven't. So if you have any advice, we'd really appreciate it.
Well, dealing with the legislative process in New York can be very frustrating. I did that for 52 years. I was able to get a lot done, but there was a lot that I wanted to do that I was not able to get done. What we need for the New York Health Act is to build broad, strong, vocal public support. And that means writing letters to the editor, writing op-ed articles in your neighborhood paper, getting all the different organizations that you belong to learn about the bill and to endorse it, and to reach out to your assembly member and state senator and make sure they know that you really want them to bang on pots and pans to get this bill done, so that they will press their legislative leaders to get the bill done. That's how we move things in a small d democracy. We've got to, as rank and file New Yorkers, we've got to build support, get the word out, make sure people know about the bill and how much it can benefit them, and make sure we and the organizations we belong to and our friends lean on our state legislators and help get the word out and press them to lean on the legislative leadership so that we can get this done.
Thank you.
You know, it's a lot of work, but it's really important.
Thank you, Jacob, for being so generous with your time and your answers. We really appreciate it. Give a hand to Thanks, Dave. We'd like to thank the League of Women Voters for sponsoring this event, and if indeed you would like presentations or whatever, you can get in contact with us for doing any presentations to any organizations or clubs that you may think would be interested. We have some yard signs in the back. They're single-sided and double-sided. Yard signs, double-sided with stakes, and then single-sided ones if you want to put them in a window. We ask for a $5 contribution to offset the cost, but if you don't have that, then certainly take a sign as long as you promise to display it. So we'd like to thank the League of Women Voters of Tioga and Broome County, and these great people, and Edward, our IT fellow, for setting it all up and doing it. Very, very nicely done. So thank you very much for having us, and I hope to see you again.
Thank you. Thank you, and you've done a great job supporting the bill.
Yeah. Thanks, Dick.
Bye-bye.